I see Brian is here, so we'll go ahead and get started. This session is on next generation surveillance. So I'll let Brian take it away.
Thank you, Steve. If people want to come in, we'll get started. Okay, good. Thank you. This morning was a great setup, purely designed to set up this session. Of course, as multiple people called for the existence of pharmacoepidemiology studies using structured data for pharmacoepidemiology phase 4 studies. We've been those of us in the field have actually been doing it for 40 years, so that it's not novel. But what you'll hear about today is some information about state of the art about using structured data for pharmacoepidemiology studies from Rich Platt in terms of the Sentinel system, and then talk more in the other speakers about surveillance, about screening for adverse reactions. I should point out, by the way, also in follow-up of the discussion this morning, the issue of claims data and medical record data that we've gone back and forth this morning. Those of us who've been in the field using it for decades basically don't use U.S. medical record data for because it's not population-based. We go to the UK, with the exception of what Rich does, which linking it to claims data in order to be population-based. Because otherwise, I came from the University of Pennsylvania. I'd see a patient at University of Pennsylvania. If my patient had an adverse reaction and went to Jefferson for that adverse reaction, in an electronic record system in the U.S., you wouldn't know that. And so it's why you need population-based data. It needs to be complete. Rich will describe to you how they've solved that problem within Sentinel. So, Rich?
Okay, terrific. And Brian, you haven't personally been working for 40 years in this area.
Correct.
Okay.
Thank you.
So I took the opposite tack from Russ Altman, and I gave myself a new title for my presentation. I'm going to talk about the FDA Sentinel system. The impetus for the Sentinel system was the FDA Amendment Act of 2007, which required the FDA to create the capability to use electronic health data from at least 100 million people to assess the safety of marketed medical products. So this is right in the sweet spot of a lot of the conversation that we've been having, and I'm delighted to tell you that FDA has been pushing the ball forward for since 2008, when it announced the Sentinel initiative. I had the privilege of speaking to this forum in 2011 about what we were planning to do, and at that point, I think I would have called it next generation surveillance. But what I'm going to talk about today is surveillance that we're doing now. So three major flavors of safety surveillance: hypothesis-free signal identification, signal refinement. We think there might be something. Can you tell us whether there's something there or not? And then signal evaluation, which is a full protocol-based analysis. The system we've built is one that rests on routinely collected electronic health data, and the middle band are the data partners who are making their data available. Okay, we could have a discussion about whose data is it really, but it's data that they are in possession of. And I'll point out that this includes 5 of the 6 largest national health plans, plus Hospital Corporation of America, which is 160 hospitals, does about 5% of the acute inpatient care in the U.S. So lots of organizations. For reasons Brian just emphasized, the foundation is administrative data, and the reason for that is if you have attended medical care in this country for which somebody pays a bill, then it's possible to know that that occurred from the date your coverage begins till the date your coverage ends. And so that defined person time is the foundation on which we build everything else. There's an additional reason, which is the data are just better behaved. We add to that electronic health record and laboratory test result data for about 10% of the population. And that's when we learned that if you want to use something simple like platelets, you should be prepared to do hand-to-hand combat. When necessary, we link to public health registries like state immunization registries or birth certificate registries. And every one of these organizations has the ability to go back to original full-text medical records when necessary. but it's a slog to do that. So we do it only when it's absolutely necessary. For instance, if you want to know whether that diagnosis of intussusception is real, you really need to have expert adjudication of the records. Each of the organizations transforms its data into a standard format. The common data model looks like this. It's a series of linked tables that has enrollment, demographic, dispensing, encounter, lab result data. Not every organization has all these kinds of data, but if they have it, they put it into this form. So since we had such a splendid discussion in the last session about the vagaries of data and the need to do curation, I'll skip over that. But let me just say that this is when we envision the vast information highway, like a transcontinental highway system. This is really more like the Lewis and Clark expedition to be doing this kind of work. Now, the reason we're able to do that is we actually, we don't accept data from any of these organizations. If we said, would you provide your data so we can do this entirely worthwhile work on behalf of you and the American public, we'd still be having that conversation. Instead, what we say is, will you answer a question to each of these data partners? And we do that because now that they have their data in a common data model, we send them executable code. They don't change the code at all. There's one line where they say, the data live in a directory named X. Otherwise, the code runs on the data that is now in a uniform format, and they return the results, and those results are almost always aggregated data like counts. Occasionally, it's a risk set. Very occasionally, there's person level data that's the smallest number of data elements needed to do a regression analysis. This is a method we developed with the Office of the National Coordinator, and they use it as a reference standard for their Query Health initiative. As a result of doing that, there's now a very large distributed data set that has hundreds of millions of person years of pretty well curated data. Before we use the data for anything, we do a series of 1,400 data quality checks. We consider them first level. They get us to the point where if FDA asks us a question, we can usually be confident that we can run code on it. But if it's important, we have to do additional curation. So Sentinel was set up as for the first 5 years, it was called Mini-Sentinel. It was a pilot project, and all we were supposed to do was get our arms around the damn data. But it turns out in the process of doing that, FDA issued 4 drug safety communications on the basis of studies that they asked us to do. It was also the basis of dozens of presentations by FDA, bunch of peer-reviewed articles. Sometimes, although this is done to support regulatory decision-making, sometimes the work of Sentinel is of sufficient quality that reasonably good journals are willing to publish it. And sometimes we get a shout-out about having created something that's broadly useful for the public. I hadn't realized until earlier this year that the original enabling legislation required FDA to do a mid-course evaluation by a neutral third party of Sentinel, and that was posted on the FDA website last month. It's called the Sentinel Program Interim Assessment FY15, great title. So it wasn't really about us, it was about the whole program, but it turned out pretty well. I won't read them all to you, but it's basically for 5 years in, the program got pretty good marks. Now, so there's this ongoing stream of work. FDA is asking us to, the things that are sort of in FDA sites and therefore in our sites now are these. One, to really integrate Sentinel into the regulatory decision-making that they call Active Risk Identification and Analysis, or ARIA. And that's mostly in the Center for Drugs. In the Center for Biologics, we've been focusing mostly on vaccine and on vaccines, and they've asked us to be more to build a stronger program in blood and blood product safety investigation, and that's a principal driver of our bringing on the Hospital Corporation of America, because most of the blood exposures occur in hospitals, and we need that inpatient data to sort that out. We're adding important new data resources. We expect to have a to be able to use CMS data soon, and I've already described the work we're doing to stand up the inpatient EHR data, and there's active discussions about using DoD, VA data, and linkage to the PCORnet EHR data. Worth mentioning in my last 90 seconds that we're also working with the Reagan-Udall IMEDS program. We're in deep conversation with the Biologics and Biosimilars Collective Intelligence Consortium. I don't know what those glowing dots are, but I gather we're going to study them. FDA has been very good about instructing us that it intends the resources and capabilities we're building to be used as a national resource for purposes in addition to medical product safety assessment. And so with NIH support through the director of the office initiative called the Healthcare Systems Research Research Collaboratory, we've built the Collaboratory Distributed Research Network, which provides a mechanism for NIH and other investigators to work with these same Sentinel data partners if they wish to do that, but freed of the requirement that they be able to sort of align with FDA's interests. And we are also the coordinating center for PCORnet, which is a major undertaking to support CER research. That's built on a foundation of EHRs, but we've built the common data models to be consistent with one another so that it's possible to do work across those. Everything I've described here is on the website, which hasn't yet changed its name to the sentinelsystems.org website. Thanks very much.